Get started now. Today we have approximately 45 minutes, and just a reminder, one question, one follow-up. We have Dr. Williams and Dr. Brown here today, so I'll turn it over to them to get started.
Right, well, good afternoon, and it's Thursday, and it's been 2 weeks. So today again, we're fortunate to have Dr. Brown provide us with an update on the COVID-19 projections. So we're looking forward to that presentation. And following that, and some comments, I'll have some reflections on our numbers that we've seen since our briefing on Monday, and on the with Dr. Brown's modeling as well. So with that, because I know there's a fair amount to present today, I'm going to hand things over to Dr. Brown and his presentation. So thank you for being with us today.
Thank you, Dr. Williams. So this week, we will share data that has some hope in it, but it's hope that requires a commitment. The third wave of COVID cases appears to be cresting now. The strain on our hospitals will continue for some time. If we keep our commitment to getting our case numbers down, we can sustain our health system, and we can look towards a new normal that is hopefully better than the one we left when the pandemic started. All of us are doing this together. In the decision to stay home, to stay away from work when you're feeling ill, and the decision to wear a mask when we are out. If you run a business, this curve is turning around because you're helping your employees to stay home when they're sick, because you're keeping your workplace safe, or, as hard as it is, closed. Vaccination is increasing in our hotspots and has just been announced. Doubling down on this commitment means the cases will come down faster. So thank you. So there's clear reason for hope, but this hope requires a commitment, a dead-set determination to see the job through. It requires staying the course and making sure that we make the third wave the last wave, that we control spread so that our vaccination efforts have time to take hold. So the three key messages in the data we will share today. First, many countries and jurisdictions have been here before. It's tempting to relax when the numbers start to turn your way, but it will not work. This is the time to commit to getting them down, to setting goals towards which you can work, to making hope the basis of a commitment to get on top of this disease rather than the excuse to relax. We still have a long journey in front of us, and please know that the way down will be slower than the way up, particularly for our hospitals. So while we've had a good start, it's nothing more than that. We cannot afford a fourth wave, and we cannot let the new variants into our system at such a challenging time. This means we need to restrict movement into and around the province. The second thing I take from these data is that we, Ontarians, actually have the power to turn the tide of this pandemic. The third wave isn't cresting on its own. You are making it happen. It's happening because of our daily choices together. That's important. And as we continue to make these decisions that protect all of us, we give the vaccination campaign time to succeed. I want to note as well, though, that these are very hard decisions, and they're harder for some populations that have to go to work, our essential workers. And so we should never forget that it's not just about choice, it's also about the circumstances that people face in day-to-day lives. Finally, you'll see how the impact of COVID-19 is as enormous as we describe it, and it does stretch beyond just patients with the disease. Our healthcare system is no longer functioning normally. We're taking the most critically ill patients, we're putting them in helicopters and into ambulances, and moving them across the province because we're searching for beds. Nurses and doctors are attending to patients in field hospitals. We are now backlogged 250,000 surgeries. I'm grateful for the providers from across Ontario and across Canada who've rallied to help our most challenged hospitals. It's important to note that this is an incredibly challenging time for our health system, and that has not changed, even with a crest in the case numbers. Other stories have shown this week how ruthless COVID-19 can be. We have to be equally ruthless with this disease, and we need to commit to getting our numbers down once and for all, using all the available means at our disposal. We know what to do now, and it's starting to stick. It's starting to work. And this can give us all hope. The key thing now is to stick with it. We have the power to end this pandemic if we stay committed to the course. But before we get into the numbers, I do want to add one more important thing for Ontarians. We are as worried about the missing patient as we are about the wave of COVID-19 patients in our hospitals. We know that there are people who need care, who need to be in hospital, who aren't coming, people who need urgent attention. While it's true that our hospitals aren't functioning normally, they're still able to care for patients who need urgent help. To be clear, it's not safer to stay at home when you need help, even now. If you need a hospital, please get to a hospital. With all that, let's get into the numbers. And my apologies, as we move into the presentation, the sign language translation will disappear. It'll return immediately following the presentation. Great. So let's start with the key findings. As I said in the introductory comments, the efforts of Ontarians are making a difference. Cases are cresting, but they're cresting at a very high level. ICU occupancy is at record highs and continues to climb, and our system is under incredible pressure, unlike it's ever faced before. Workplace mobility is still too high. Limiting essential workplaces and keeping sick workers at home will help control cases. Clearing the surgical backlog will be an enormous challenge. Vaccination distribution is more equitable because it is focusing on hotspots. Continuing this progress and increasing the vaccination rates in our hardest hit communities will be essential to progress. Ontarians can make outdoor activities safer with distancing and masking when close to those outside their household. Indoor activities, I want to remind people, pose a significant risk. So let's look as we start as we always do by looking at case rates across public health units in the province. You can see that cases are flattening, but pockets of growth do remain in hotspots. And this level of growth, in some cases, is still exponential, and that's the type of growth that can explode very, very quickly. You can see here that there are an increasing number of public health units, although still not the majority, that are reducing their cases. And I should point out as well that the case rate right now is still very high, what we consider well above the control or red level in the province. For those of you who've been looking at the recent or are interested in the recent reproduction numbers, the tendency or the likelihood that someone passes the case on to other people, it's about 0.9 right now. So that means that we're starting to see a deceleration. We're starting to see a cresting in the number of cases. But important to keep in mind as well that the number of cases is still very, very high. Here we're showing test positivity rates, the proportion of tests that are positive. These are still very high across Ontario. You can see that it's about 8.9% when we calculated the chart earlier in the week. It's fairly consistent at this level, and this again is a very high level of positivity. This is above what we would have considered before, above the red or control zone, so it's a very high level of positivity. So high case rates, high positivity rates. And if you look here on this slide, testing rates are flat or a little bit down. So we always look at three numbers when we look at the current state of the pandemic. We look at the number of cases, we look at the percent positivity, and we look at the testing rates. And so cases are flat, positivity is high or maybe up a little bit at times, and testing is flat or a little bit down. All this means is that the current plateau is very precarious. This is the place where you can either start to drive down the pandemic, drive down the case rates, drive down the number of hospitalizations, drive down the number of admissions to ICU, and drive down the number of deaths. Or if we see a change, as we've seen in the past, you can see substantial exponential growth in the cases and really a continuation of the third wave or a fourth wave. Continuing on here, you can see the proportion of cases, which are variants. The orange part of the graph represents the cases that are variant-driven cases, predominantly the B117 variant, which is the variant initially identified in the United Kingdom. As you can see, and as predicted, the proportion of cases that are variants is exceedingly high. It's now more than 90% of all cases are a variant, a new variant in the province. Although most of them are B117, the prevalence of the other variants, the ones that were first identified in South Africa or Brazil, are increasing, and we have seen now in this country the variant that was first identified in India. I think it's important to point out that as new variants emerge, it's critical to keep control over the entry or restrict entry into the province so that we control the entry and the spread of potentially more dangerous variants that could be vaccine escapees. Let me go on now to mobility. Mobility within your community is really a marker of risk behavior. It's not a exact sort of correlate or cause, I should say, sorry, of case spread, but it's a marker of high-risk behavior. What's good here is that mobility has come down substantially. This is overall mobility. You can see a dotted line on the chart. That's the mobility threshold, the rate of mobility or the level of mobility at which we think it's necessary to be below to drive down case rates. You can see that mobility here has now crossed that threshold, and that's what's helping create the crest in cases and hopefully a decline in the number of cases. I will say it was steadily down when we calculated this a little earlier in the week. The data from today looks like it might be slightly up, so it's important to consistently and constantly try to keep this mobility limited as well to try to keep case numbers down. Here you can see 3 different types of mobility. I think it's really important to note that retail and recreation, transit mobility, those have had very, very clear drops, but workplace-related mobility remains too high. And reducing this mobility will help us further drive down overall mobility and help us further drive down case rates as well. And if you just look at the pattern here, you can see that on the latter two, the middle and the right-hand side panel, we've driven down mobility close to where we were during the January lockdown. You can see that workplace mobility remains higher and still creates a threat to controlling the disease. Now, moving on to the case rates, you can see here that cases are decreasing earlier and faster than projected, which is good news, but will only reach February levels under the best case. If you look at each of the lines here, you'll see a different set of assumptions, and I should note that these are representative cases. We work through 5 different models put together by different modeling groups across the province. Each of them run multiple scenarios with different assumptions, and we try to give a consensus or coherent sort of idea of what the different scenarios present. The red line is where we would have been had we not had the stay-at-home order. And so you can see that there has been substantial control over cases because of the stay-at-home order. Right now, the list of assumptions that would really define that mid-case, that yellow line, is about where we are. And current progress, or current sort of last sort of 7-day average for a few days, is just below that yellow line, suggesting that's probably a fairly good prediction of where we are at about 1% decrease every day. The green line is where we have strong effective sick pay, a short list of essential workplaces, lower mobility, and a continued focus on vaccinating high-risk communities. One of the things that we'll have to continue to understand is how vaccination increases. Any increase in vaccination will help drive down numbers. It's important to come understand how behavior holds or doesn't hold during the pandemic. That'll also determine where these go. But you can see that if we start to relax public health measures, after, say, 6 weeks that would have started on April 8th, you can see there is a potential for an increase in cases again, which could be quite dangerous given that our ICUs have not yet started to empty out in any way. I want to try to drive home this point here. If you look at this chart, which we show every time, the orange lines are the hospitalizations with COVID-19. And the red lines, that sort of lower level, are patients in intensive care units with COVID-related critical illness. And whereas you see the crest of the second wave coming back down, and then the start of the third wave, there's no decrease really after the second wave in intensive care unit occupancy. And that's why as this new wave hit and started to rise up, you really saw the intensive care unit occupancy building off of not a low level like we would have had during the summer, but a much higher level that had been a result of the second wave. And so we know that care in the intensive care units will persist for a while, and it's this occupancy of our intensive care units which is such a significant threat to currently to our health system. Going on, here you can see the projections on ICU occupancy. Although cases are lower than we expected, ICU occupancy is still on track for the projections, and unfortunately that does take us or keep us above 800 for a while. Under the best case assumptions, it starts to come down to about 500 by the end of May, to perhaps just a little bit under 800 by the end of May if we're on a moderate or sort of the middle case set of assumptions. It's important to note that that's still a very high level and may not be sufficient, unlikely to be sufficient to restart surgeries in a significant way as we move along. Moving on, just talking to the issue of transfers, you can see that there has been a dramatic rise in transfers between hospitals over the last 2 reporting periods. This really reflects 2 phenomena. It reflects patients who need to be sent to another hospital than the hospital that they arrived at in order to get the care that they need. It also reflects an intentional movement of patients to create capacity in the hardest hit communities, in the hospitals in the hardest hit communities. So this really reflects kind of the state of the system, where we've got multiple transfers, where we've heard in different stories over the last little while, patients being moved to much different parts of the province, sick families being split up, and this is likely to continue for a while ICU occupancy remains at such a high level. We also report on this figure each week. This is the current surgical backlog, and it presents an enormous challenge. As you can see here, the current surgical backlog is over 250,000 cases right now. And it's important to note that this is really one of the waves that will hit our health system as the backlog needs to be dealt with. There's also the backlog from missed screening, which we've talked about in earlier briefings. There's the backlog from increased chronic disease around increased unemployment that's happened during the pandemic. And there is the backlog that will happen from increased mental health and addiction challenges, which it may be hard for us to estimate right now, but as we've documented in previous briefings, are significant challenges. Moving on to vaccination, and some good news on vaccination. When we did this slide earlier on in the week, it was 4.5 million doses administered. It's now close to 4.7, or around, I should say, 4.7 million doses. Coverage in people 80 plus is very high. Coverage in people 70 to 79 has increased substantially. The dark blue part of each of these figures represents people who've received at least a first dose. The light blue really reflects people who've made an appointment for the vaccination. Yellow reflects people who are still waiting to be vaccinated or who have not signed up for an appointment or have not received one. You can see it's improving as well in the 60 to 69 age category. Still a long way to go, though, in 50 to 59, and obviously under 50 still very low, although improving levels of vaccination. And this is an area where we're starting to see trends in the right way. If we vaccinate in the hardest hit neighborhoods, if we prioritize the neighborhoods that have the highest incidence of disease, we know that we will help control disease in these communities. We know that we'll help to control disease across the entire province, and we know that we'll help to make some aspects of the pandemic a bit more equitable. And as you can see here, it has changed since the first briefing where we showed this chart. In the first briefing, the difference between the top, the highest incidence community, and the lowest incidence community was about 3.5-fold. And this means that if you were living in one of the lowest risk communities, in the lowest incidence community, you're about 3.5 times more likely to get a vaccine than if you were living in the highest risk community. You can see that those numbers are roughly comparable, and that trend needs to continue so that you see that the people who live in the highest risk communities have the highest level of vaccination by far. You're starting to see some of this trend in the age group between 50 and 69. This is positive, and this is a trend that needs to be reinforced and encouraged as we go through control of the pandemic. I want to finish off the new slides today really talking about the fact that outdoor settings are safer. It's about a 20-fold lower risk to be outside, but it's still important to take precautions when outside. If you are outdoors and you can physically distance from other people who are not in your household, you probably don't need to wear a mask. But if you can't, then you do need to wear a mask. And so if you're out for a walk in a park with your own household, you can effectively physically distance from other households. Probably okay not to be wearing a mask, but if you're, say, on a playground, it's important to try to wear a mask to make sure that you prevent the transmission of these highly, highly, highly transmissible variants. So back to the key findings. Cases are cresting right now, but they're cresting at a very high level. ICU occupancy is at record highs and continues to climb, and our system is under incredible pressure right now. Workplace mobility is too high. Limiting essential workplaces and keeping sick workers at home will help control cases. Clearing the surgical backlog will be an enormous challenge. Vaccination distribution is more equitable because it's focusing on hotspots and it's more effective. There's no trade-off here. Continuing this progress is essential. And Ontarians can make outdoor activities safer with distancing and masking when they're close to those outside their household. Indoor activities do pose a very substantial risk of transmission, and not just in that setting, in every other setting to which those people move afterwards. With that, I'll move to a quick view of the contributors who've helped with this week's briefing and provided material. And then I'll close on the members of the consensus table and the scientific advisory table who've provided this information. Thanks. Dr. Williams, back to you.
So, well, thank you very much, and as always, very valuable to see those projections, and this time with some optimism. As we talked about earlier, I may have some concerns also with some recent data points that might, I'd say, like the weather, rain on that a little bit. We have to really be careful, and I know Dr. Brown has alluded to that. We're in a very precarious plateauing level at this stage. So I'm going to talk about some numbers here, and let's look at that and see what I'm talking about here. Since we last reported, we have had 10,616 additional cases of COVID-19 since Monday. And that's a significant amount. As Dr. Brown said, we're plateauing maybe at a very high level, not at a low level. And I want you to pay attention to the numbers as I tell you here how we went. On Tuesday, we had 3,265 cases. On Wednesday, we had 3,480 cases. Today, we're reporting 3,871 cases. And I'll tell you what we're projecting for tomorrow in a moment. So you can see a steady increase as our volume of testing has gone up and our percent positivity has stayed up. Ontario's current 7-day average for cases is at 3,810. The good news is that was down from 4,176 last week and down further even than 2 weeks ago, where it was at 4,208. So the provincial case rate has also decreased by 8% for the latest week of full data. However, the rate is still high, as Dr. Brown has noted, at 191.1 cases per 100,000 people. Sadly, we're reporting an additional 94 deaths since Monday's update. This includes 41 deaths today. And very few of these deaths are related to our congregate settings, as in long-term care and residential homes. That means more people are passing away outside of those settings, and younger age groups are being involved, and some who are in fairly or relatively healthy states. This is concerning, and mostly it deepens our sympathies to the families and friends that have lost loved ones in this way, especially ones that had not had any predisposing factors. The number of patients in hospital and ICU remains elevated, as Dr. Brown and the data has noted. 2,248 people currently hospitalized, and 884 in our ICU. Getting back to the data that concerns me, I told you the rates that we've seen rising up until today. Our data shows us that we are testing 56,939 tests were processed today, and the positivity rate is 7.6%. For those who do the math, that means we could easily be over 4,000 tomorrow. So that means our plateau has edged up back again. As we've seen in other weeks, this is a trend direction as we near the end of the week. That rises on today, or tomorrow and Saturday, and then comes down again with volumes. But that's not a reason to say it isn't important. It is important because we're seeing this plateau, and as Dr. Brown has alluded to, we have to watch this very carefully. Let's stay vigilant, let's stay at the task, and keep this turning back down again, because it is critically important at this stage. And because we're not talking about just a few extra cases, we're talking a lot of extra cases. So there are now 63,688 confirmed cases of variants of concern in Ontario. The majority, as Dr. Brown has noted in his graphs, are the B1.1.7, the so-called UK variant. We are seeing some increase, small but concerning, in the B1351, the so-called South African variant, and the P1, or the Brazilian variant. Nowhere near the levels on the West Coast, but that doesn't mean we can't go the same way. So we have to be really cautious in our care on these ones as well. Our 7-day rolling average of the positivity of the variants is 73.5%. That's down from 76% 1 week ago. but it is down just a bit, and we have to be very cautious about drawing conclusions about our success yet on this grounds. So our numbers are up compared to the previous 3 days. We were seeing early signs of improvement, and that's what Dr. Brown noted in his presentation. Our R effective, or RTs people talk about, has declined both for the so-called classic COVID and the variants. We're underneath 1. We are at that at the moment. We can easily go back up again. So we really have to buckle down and be very careful with our precautions in the next number of days ahead of us. Public health is having an effect with our vaccination rollout. You've seen some of the impacts of that as we shifted to even more to the high-risk areas. You've had briefings today from our technical group and from our ministers on the task force related to all the positive things about our vaccination program at this time. We've administered over 5 million doses, and as Dr. Brown's data alluded to, 4.7 million people have received at least 1 dose in there. And we're going to keep pressing on that as we see in the weeks ahead more of some of the vaccines arriving and how to utilize that in the most effective way to bring down our case numbers in the weeks ahead, and especially if we can bring down our hospital admissions and our ICU admissions as well. So it's all good news, but we have to keep and wait and look for that. Remember that when you get a vaccine, it does take you at least 2 to 3 weeks to build up any immunity. Do not make the mistake and think that once you have a vaccine, you can throw off all public health measures and precautions. That would be a grave mistake. And so you still have to do what you need to do. And even if you receive 1 dose of vaccine, because you can still potentially carry it, even though you have more protection against severity, you can still be a source of transmission. So those rules, even in outdoor, as Dr. Brown alluded to, still have to be maintained. So we have those same messages about washing hands, staying home if you're ill, getting tested when you need to be, doing isolation and quarantine as you're directed, and also following all the methods of the precautions, both indoors and the ones noted by Dr. Brown outdoors, as the weather, perhaps after this week, might still get better, and we look at to the promise of spring and warmer days ahead. So, thank you for your continued efforts on this. We made great strides last week, a little bit on the upswing this week, so we need to really buckle down and push back on that so we can continue that trend, because as Dr. Brown said, it's us collectively that's making the difference while we wait for the vaccines to be given, while we wait for the vaccines to build up immunity, and we wait to a core population of people vaccinated to continue to drive down these cases where we've seen success already in the age groups that we've done. And now we're trying to make real headway also not only in there, but in our hotspots, so-called, with various venues such as pharmacies, mobile clinics, workplaces, any means possible to make sure we get that coverage up as soon as we can and as quickly as we can. So thank you again. Stay focused, stay safe, stay healthy, and do the things you have been, and do them again and again, and we can do this together. So with that, I'm going to hand things over to the media for questions.
We'll go to the phone lines. Just a reminder, 1 question, 1 follow-up. Over to the first question, please.
Your first question comes from Anthony Fury from Post Media. Anthony, please go ahead.
Thank you for taking my question, gentlemen. And this one is to both of you. Many Ontarians appear to be just flat out rejecting and going against many of the province's outdoor restrictions, the ones that remain on the books. And we've got groups like Ontario Soccer that are formally saying these rules need to change in advance of this summer. And many municipal politicians are actually saying similar things about other activities. So what do you say in response to this considerable pushback that's happening throughout the province?
Well, I think it's a very good point, and we know there is the aspect of it's been a long year and now 16, 17 months, and people have been at it, and we're in a 3rd wave. Some people are getting frustrated and saying enough is enough, but as you can see with our 3rd wave, the ones who thought they were not potentially impacted much by consequences of COVID, that's not proving the case at all. In fact, it's to the contrary. And while you may think you can take part in an event, a sports event, as Dr. Brown was alluding to, there are certain cautions you still need to take in those. We're looking at that. If you can maintain distancing and activity and how to do it, outdoor is better than indoor, of course. But it doesn't mean outdoor congregate activities without masking, without distancing, because the variants of concern with their high levels of aerosolization, especially heavy breathing with heavy physical exertion, yelling, cheering, whatever you're doing, or engaging in conversation at close range, it can be transmitted very quickly and very easily. So we have to stay at that. We've seen where sometimes our professional sports teams with many levels of precautions and testing in place, nevertheless, have had transmission and outbreaks within their teams, in spite of a number of steps there. And that shows you how, even in young and healthy athletes, it can be moved through fairly quickly. And of course, not only just getting a positive test, and only being required to isolate and quarantine for a few days, we're finding more and more of these people, besides if they didn't get into hospital and hospitalization, some are having more long-hauling type conditions that can be debilitating. And we want to make sure that you understand that. We haven't got all the data we need on that, but it is making impacts. So I understand your frustration. I understand people want to do that. We are hoping to give more advice on some activities, how to do them in a safe way without compromising your health or of those people and teammates or whoever you want to try and do things with. How do you do it in a safe way as we work in a very high COVID reality at this time? I'm not sure, Dr. Brown, if you have any further comments, you're okay with that? Okay, well, thank you for your question. Next question.
Follow up?
Just to clarify, you mentioned outdoor congregate activities with masks. That's currently illegal in Ontario right now. It's illegal for two siblings to do that together on a basketball court or whatnot. But it sounds like you're saying outdoor congregate activities with masks is probably safe, and that it sounds like you're saying there's going to be a revision coming soon about those rules.
I'll ask Dr. Brown to comment. We're trying to we've been asking the science table for advice on outdoor. We know there is a decreased risk of transmission in outdoor. Nevertheless, one cannot throw caution away. And I know you're hearing this 2 or 3 rule, or 2 out of 3, and maybe Dr. Brown want to comment further from what the science table is doing on that. And then how does one apply that? When we talk about congregate, we're not talking like a big huddle and group that we've seen sometime in the parks where people just cluster and gather. You need those precautions. Ideally, even if you're outdoors, if you can, I would still like you to wear a mask and to keep the distancing in there. But then there are some situations where we're trying to address, can you actually do something a little bit compromising on that? We're trying to understand that better to try and give you some greater opportunities to expand on your outdoor activities without lowering your precautions and putting yourself at risk. I don't know if Dr. Brown, you want to comment on the science table review of this matter?
Thanks. So, the simple sort of rule is pretty clear. Outdoors is good. It's a lot safer than indoors. And it's outdoors plus either masking, if you can't be distant from someone, or distancing with outdoors. I think the issue right now is that all of us want to be outside. I know that none of us like the lockdowns. I find them very, very hard, and I know many people find them much, much harder. But just at this point where we're cresting, we have to be as careful as we can, and so that when we can reopen, when we hit that level where we can think about reopening schools, and then I expect sort of outdoor activities would be top of the list, given the importance of schools and the safety of outdoor activities.
Next question.
Next question comes from David Woodard from Global News. Dave, please go ahead.
Good afternoon. This question is for both Dr. Brown and Dr. Williams. You say that this report gives us some hope, some optimism, but the data that you presented, I'm not sure if that's what Ontarians are seeing. Yes, there may be some cresting of the numbers, but it also shows that these severe public health measures can't be let up and no timeline as to when that can happen. It shows that ICU numbers are going to remain high, surgeries still being put off. So where is the hope in this data?
So it's a very cautious hope. It's just the cresting of the cases, and it's exactly as you said. It's a little bit of hope, but it's not the time to let up yet.
And I would add, as Dr. Brown was trying to show you on the data and graphs, from our projections 2 weeks ago and 4 weeks ago, without some measures in place, we would be not worried about upper 3,000. We'd be talking to 8,000 to 9,000 cases a day, and we'd be a lot worse off. So we have shown again that we can impact that by our public health measures. We collectively can do that. So that's the optimism in there, because people say it doesn't seem to matter. It does matter. We are making an impact. But you can't say, okay, we gave it a couple of weeks effort, let's just roll off. That's not how it works. You have to keep your vigilance up over a period of time. And so we're asking you to stay at the task. We're looking at ways that we can get some things back to you, more of the outdoor activities as the weather improves. So we're trying to do our part to understand your frustration and your perplexity on the matter, and trying to show you that the optimism is that we are making a difference. But it is not instantaneous. We have to be strident on our efforts to keep at this for the next number of weeks if we hope to get that. Because the other thing on the other side is the vaccinations are rolling out. And in the coming weeks, we're going to get more vaccines than we had other weeks. So we're going to continue to drive that down in that way as well. It's like a race against time thing, and we need you to do your part while we get there. So when you're ready to get it, we don't want you to get it post-COVID. We'd rather you get it and vaccinate so you don't get COVID. So those are our reasons for optimism. Cautious, as Dr. Brown has said, at this time.
Follow-up?
Thank you. Dr. Williams, it appears that many people are getting side effects with the Astrozetica vaccine specifically, and I don't want to scare people from getting it. That's not the message. But can you explain why we're getting these side effects? And what do they mean? As in, does it mean that it's more effective if you get bad side effects versus none at all, for example?
So side effects, and this is one of our very important parts about a public vaccination program, is that we ask people to report very quickly any effects they're having, and we need to collect that data. Why? Not because we're concerned about the safety of the vaccine at this stage. We want to make sure we understand and watch everything, because you're now dealing with population-wide, and some of the vaccines during their clinical trials were smaller populations. Now we're dealing with a wide variety of people with a wide variety of maybe precipitating factors that may be there. We get people complaining of pain around the injection site, soreness, sometimes afterwards mild fever or fatigue. This vaccination is meant to stimulate your immune system. We're trying to get that rolling. When that happens, you get things such as feeling achy and tired a bit. You get things like a low-grade fever that lasts for 48 hours, 72 hours. There are some, and rare, more severe ones, and we want to know what those are. Are there things like allergic reactions? Because this has certain things in it that some may be allergic to, knowingly or unbeknownstly, and we make sure that we watch you for 15 minutes. If there's a problem, we can handle and deal with that as quickly as we can. There are the more rare, severe ones that you've heard with some vaccines, and we want to monitor that. And what is that rate? So far, we're looking at less than 1 per 100,000. We're talking mostly about the Astrozetica, and some of the others we see some with the mRNA vaccines too, especially people who have received their second dose, feeling even a stronger reaction in there. But that's part of stimulating the immune system. I'm not saying no pain, no gain, but it does tell you that it is impacting and making it's stimulating your immune system so that you're ready to fight off the COVID infection and not become ill, and hopefully in the future you don't even transmit to anybody. So we are monitoring. We'll be bringing to your attention if there's something of undue concern and interest. We will make sure we update you as fast as we can. That is what our adverse event reporting system is about. That's what we want to make sure that we get back to you, the public, so you're kept informed on the matter with the most up-to-date data we have.
Next question.
The next question is from Rob Ferguson from the Toronto Star. Rob, please go ahead.
Hello, gentlemen. I'm wondering from Dr. Brown, is 50% vaccines, sending 50% of the vaccines to the 114 hotspots for a 2-week push, is that enough to do what the science table wants to do? And should it be reduced to those 74 hotspots that have been talked about as being worse?
Thanks. So what we've really been pushing for is about 4 weeks of vaccination at 50% of the vaccines going to the hotspots. Anything that increases vaccination in those hotspots is good, but I think the longer we can maintain that to really get coverage as high as it can in those communities is excellent. We've not done the analysis comparing the two different sets of hotspots, so I can't answer the second question.
Yeah, and I would add, Rob, not only putting more vaccine into those areas, we're also decreasing the age in there, so we're using lots of different methods to get to those. Mobile clinics, workplace vaccinations, trying to make other centers of cultural and ethnic zones of areas of trust and confidence, using those as well. So we're using whatever we can to make sure we get those vaccination rates. And the important thing is, that Dr. Brown showed you in his slide deck, is that we had a differential in the past. We're starting to level that. We'd like to even move that even further, and so we can try and decrease the cases that we're seeing in there. But we have our work ahead of us, and this is a good step in the right direction, and following the recommendation of the science table.
Follow-up?
Yes, thank you. And again to Dr. Brown, just wondering, with the modeling that you've presented and with about 3 weeks left, excuse me, in the stay-at-home order, where do you think we're going to be on May 20th, and what do you think that portends for whether the stay-at-home order would need to be continued?
So, I just want to pick up as well as, on the last question before I move on to the new question. The impact of the pandemic is incredibly inequitable. Allocating 50% of the vaccines towards the highest risk communities is a good step. Doing that for as long as we can to make sure that we get those rates down in those communities as far as we can is an even better step. But it's not going to be enough to eliminate the inequity of the pandemic in any way. It's on the broader question of the equity of its impact, it's a good step. Where we'll end up in the middle of May, I think the case counts are pretty clear. I think we can hope that they may be lower, but that really requires us to get to those best case assumptions. What I'll want to say is that you can't really base it, though, only on the case counts. We need to see the case counts down. We need to see the ICUs down. And we need to be looking at the vaccine coverage, assuming that it continues well. That'll be hopefully good news, but watching that vaccine coverage and its impact. So we need to make sure that we get a whole bunch of things down, not just the case counts. If we are still at a very high level of cases in the middle of May, it would likely mean, if you want to continue to push the cases down, that you need to actually push down further and probably maintain public health measures.
Next question.
The next question comes from John McGrath from TVO. John, please go ahead.
Dr. Brown, I'm looking at slide 9 and the best case assumptions, the effective sick pay, shorter list of essential workplaces, lower mobility, and continued focus on vaccinating high-risk communities. I know you were just talking about the priority for hotspots, but you've also, I think, probably been paying attention to developments in the last few days, including the new paid sick leave law. Without asking you to predict where policy and politics might go from here, as of today on Thursday afternoon, is the current policy status quo compatible with the assumptions of the best case scenario?
No.
And with the modeling assumptions show a rebound, the possibility at least of a fourth wave. And I'm just wondering, given the levels of vaccination that we are anticipating based on the briefing we received earlier today, it's surprising to me that there's a potential for at least such a strong rebound. And I'm just wondering if you could explain, how would there be that rebound when the soil is not going to be quite as fertile for the virus in May and June?
So, it's a very good question. The rebound, particularly on the best case, is a relatively low rebound. You can see it starting to crest already there and then coming back down. So it's a smaller rebound, and you can see even with the moderate case, it starts to crest there in the chart on the cases. So it is a smaller rebound than we might have seen, and hopefully it's something that we can control and that it doesn't impact the system too much. Now, I guess the point here is, it's not just the level of cases, though. As we get more and more vaccination, as we get more and more people protected against the disease, it's also about the other indicators of health system and public health system capacity so that we can kind of reopen without jeopardizing the health system. Reopening at a high level of ICU occupancy, reopening at a place where we can kind of throw that system back into crisis is not what we want to do at this point if we want to protect the health system.
Next question.
Next question comes from Jeff Gray from the Globe and Mail. Jeff, please go ahead.
Oh, hi. Thanks, Ed. Just picking up on that, the green line assumes effective sick pay. So is the 3 days that we've just learned about and seen passed today in the House, is that effective sick pay?
So we've modeled the strong effective sick pay as beginning immediately, lasting for essentially 2 work weeks, so 10 days, and being at a level that allows people to not have to make difficult choices. What you saw is something that goes, it deals with right in the quick initiation of it, paid through employers. It's at a higher level, and it is for a shorter period of time than we'd suggest is necessary. So it's a good start, but it doesn't reflect the assumptions that we've made based on the programs we've seen elsewhere.
Follow-up.
Just follow up on a previous question about the line that then dips, or not dips, but goes back up into June and July there. That's assuming the stay-at-home order ends on the date it's supposed to end. Is that right? Or so is it possible that if that is extended, that line then changes? We don't see that return?
Right. So we presented modeling at the last briefing that showed what a longer stay-at-home order would look like. I would assume, I think you can safely assume that it's the same type of difference. The longer you stretch out that stay-at-home order, the further you press down the line, the more time vaccine has to take a hold, and you may not actually see a rebound if you're able to continue it.
Last question.
The last question comes from Randy Rath from CHCH TV. Randy, please go ahead.
Yeah, hi, doctors. Thanks for taking my question. Dr. Brown, you said something earlier that I didn't quite catch about a variant escaping the vaccine. It seems to me that you were saying that you were worried that a vaccine or a variant that has escaped the vaccine would take over in a fourth wave. Could you elaborate on that? And what were you saying?
So right now, the dominant variant that we have in Ontario is vulnerable to the vaccines. The vaccines do work against that variant. But we know that some of the vaccines, for instance, the Astrozetica, have not performed well against some of the variants. For instance, the B1351, the South African variant. If we see new variants entering the province that actually don't respond to the vaccines, that creates a real challenge because it means that the vaccines don't provide that protection.
Follow-up.
We've heard all along that, take any vaccine you can get. That seems to put into question the AstraZeneca vaccine and its efficacy and if people should wait to get a different vaccine, does it?
No. What you see right now is a variant that is susceptible to the AstraZeneca vaccine, the B117, which is the overwhelming dominant vaccine. If we can get that level of protection up in the population, that will really help bring down the pandemic and allow control of any variant coming in. I think, in some ways, our greatest concern is about variants coming in that we really don't know much about, which is why restricting entry into the province is really important. But, if you make this sort of a personal question, I'm on a wait list right now for an AstraZeneca vaccine.
And I would add that I think we're at the federal level with our team, our CMOHs. We are reviewing the matter. We have found, like Dr. Brown has alluded to, the early study with the AstraZeneca, with the South African, the study had some questionability on it. We're reviewing that matter. We're still looking at it has a 58 to 68% efficacy against all the strains at the moment with one dose of the AstraZeneca, higher with the so-called mRNA vaccines. And then we're going to get some more data shortly when we start to move into the Johnson & Johnson. The 2-dose has even more effectiveness on that. So still the risk of COVID is way much higher than any concerns on with the AstraZeneca vaccine. And like Dr. Brown's book to get his and other people there, because when your turn comes up, pick whatever vaccine you can get to move on that one there. And I know people have asked some questions about in the future if we have other ones. Our National Advisory Committee is making recommendations looking at whether one can mix and match if we have to, because supply is an issue. And sometimes you get more of one and some more of another. We've gone through a little bit again of a quieter period, but we're looking for more vaccine to come in the next few weeks. So we really hope to pick up the pace again and try and get as many people done as soon as possible. So be patient when your turn comes up. We would like to see you. We want to make sure you get your vaccine and we get it as soon as possible.
Thanks, everyone.